The co-chair of the session for this session is Dr. Hazim Burui. He is Associate Professor of Neurology at National Hospital. I would like to request him to have a seat and start the session. The chair of the session is going for prayer. He will come, Dr. Ismail Khatri. He will then have a seat. Dr. Hazim Burui.
Organizing committee for arranging such a beautiful and very memorable event. I must appreciate this. And second, visit to Karachi is always very pleasant for me. And sometimes I feel myself that it's my second city. I belong to Lahore basically, but it's really the love I got from the people of the Karachi, my senior faculties, and it's really memorable for me. I really appreciate this. And with the start of the name of Allah, Bismillah Rahman Rahim, and sometimes I feel really obsessed. Why did I show this slide in all my presentations? But believe you me, I really mean it from the core of my heart. And please take care of this piece of land. This is the most beautiful piece of land to me and of course to all of you. It's me on the slide. Right now I'm working in the heading the 2 hospitals just to further because there's no other persons. I have been asked to say update aspects of the Korea with you people. It's just a sharing of the updated aspects only. As we all know, the Korea has been updated mainly in the 4 segments: the definitions, the pathophysiology, genetics, the causes and treatment. The definition has been expanded to explain the whole spectrum of the Korea movement. I will explain later on. With the help of the most sensitive and high-tech gadgets, the different circuits within the basal ganglia have been properly identified, but believe you me, still a lot of things has to be done and still not the whole mechanism is not fully understood. The same is true, a lot of things, genetic linkages have been attributed to the genetic or hereditary causes of the Korea. The various biochemical mechanisms that may lead to chorea have also been identified, making a list of chorea long. There may be more than 100 causes that may be associated with the choreiform movements. A lot of things has already been done for the treatment aspects, but still there are a lot of things in the pipeline, but we need a more refinement. Maybe in next couple of days or years, we got a good standard of treatments for the chorea management. How the term chorea was developed is that chorea basically is a borrowed Latin word that derived from the Greek chorea, means a choral dance, a group of people they usually dance. And sometimes these are historically these things are attributed to the dancing mania, in which a thousand or hundreds of people they start dancing over hours or over days. They in the Middle Ages. So the things that develop from the Latin words mean dance. The ad hoc committee on classification of the World Federation of Neurology defines chorea. It's a busy slide, but as a definition that has to be completely a state of excessive, spontaneous movements, irregularly timed, non-repetitive, randomly distributed, and abrupt in character. These movements may vary in severity from restlessness with mild intermittent exaggeration of gestures and expressions, fidgeting movements of the hands, unstable dance-like gait, to a continuous flow of disabling violent movements. So this definition basically has been expanded. It will tell us simply, it may be a very mild, simple restlessness, or it may be at the other spectrum, it may be a disabling violent movement. As we all know, basal ganglia has been a culprit in so many movement disorders, and chorea is one of them. It's just refreshing. I will give the slide. Just remember the refresh you the few names: caudate nucleus, putamen, globus pallidus, interna, externa, subthalamic nucleus, substantia nigra. And when putamen, globus pallidus combinedly, we call it lentiform nucleus. And lentiform nucleus with caudate is basically corpus striatum. That is the main focusing area in development of the different movement disorder, including the chorea. And believe you me, I have studied all the circuits, and it was so complexity. I did my best, believe you me, just to make it very simple for you people, and it took me a long way. How can I make it a very simple? but I try my best. Maybe I succeeded or not, it will be decided by you people. Basically, just as a, if you remember the whole circuits, basically we have two impulses. One is cerebral cortex and second from the substantia nigra. These two impulses, they are funneled through the pallidum, and from pallidum they go in the motor thalamus and they back to the cerebral cortex. This is a simple one loop you can say. But these impulses, they all are modulated in striatum, that is the lentiform nucleus and the caudate nucleus. From these striatals, they have two segregated and parallel direct and indirect loops. They through the medial pallidum, they enter in the lateral pallidum, and ultimately they end in the subthalamic nucleus. And subthalamic nucleus is basically, to me, it can be a very important structure. As when this subthalamic nucleus is activated, it drives the medial pallidum to inhibit the cerebral. It inhibits the cerebral impulses, so it can induce the Parkinsonian features. And when there is subthalamic lesions, it will enhance the motor thalamic activity, leading to dystonia, chorea, tics, and the most important, the ballistic movement, that's the ballism. So this is a basic structure. So most of the drugs, they're basically using the same thing, the same mechanisms to inhibit the impulses or to generate the things. So amongst all the different causes of chorea, the Huntington chorea basically is only well-studied model in chorea. In Huntington disease, there are basically 7 theories, but the most important, the 4 are we take the important things. The first thing is the dopaminergic mechanism. It's very simple. Means there are more dopamine. The contents of striatal dopamine, they are normal, but the surviving but diseased medium-sized spiny striatal dopamine neurons, they are diseased. They cannot use the available dopamine. This observation is very important, has led to the 2 important clinical observations. When we use dopamine depleting agents, reserpine or tetrabenazine, or we can use dopamine receptor blockers, neuroleptics, they both decrease the dopamine and the chorea improves on the basis of this. On the other hand, the levodopa increase dopamine and they induces chorea. So this is basically a dopaminergic mechanism. Still, it's not 100% clear, but the best possible explanation is that the most likely the dopamine content is more that may lead to the chorea. The second is the cholinergic mechanism. If you allow me, I will remember my 3rd-year days. This is the most important, still imprinted in my mind. There is a balance between acetylcholine and dopamine in the striatal neurons, and this is a very critical balance. In Parkinson's disease, dopamine is reduced, acetylcholine is high, and this same mechanism is responsible for the chorea production. Again, there are certain things, as we all know, the anticholinergics improves the Parkinson's disease, especially the tremors, and it also improves the bradykinesia. But on the other hand, anticholinergics also produces chorea. How? The dopamine that is relatively is high because of the anticholinergics are blocked, acetylcholine is low. So that will produce, and that is also, they studied that IV physostigmine temporarily relieved chorea if it is induced by anticholinergics. In Huntington disease, there is a patchy reduction in choline acetyltransferase in basal ganglia that catalyzes synthesis of acetylcholine. So acetylcholine levels are low, that make the available dopamine higher. So it's not a balance. At the same time, the dopamine is high that will produce the chorea in Huntington disease. The third theory is serotonergic mechanism. Although they are not much clear about this, but the people they have worked with this, fluctuation in striatal serotonin may play a role in genesis of many movement disorders. SSRI fluoxetine may induce or aggravate Parkinsonism, akinesia, myoclonus and tremors. But still things has to be more clarified, maybe in next couple of years. The fourth one is the GABAergic mechanism. Most consistent biochemical lesion is patient with Huntington chorea It is the loss of neurons in basal ganglia that synthesize and contain GABA. So if you allow me to just recap, just to give you a good impression to impact on your memory, we have basically dopaminergic, the direct mechanism. The dopamine is an increase in the striatum, and cholinergic means indirectly we are increasing the dopamine level. And third is the GABAergic mechanism. There is a loss of neurons in the basal ganglia that synthesize and contain GABA. You can well appreciate the long list of causes that has been attributed to the recent development of the high-tech gadgets and most sensitive tests that make the possible the different causes that may lead to the chorea. I just give you some clues. The inherited causes, now they are more increase in number of hereditary causes. Ataxia telangiectasia, benign hereditary chorea, pantothenate kinase associated neurodegeneration that previously called head and Watson-Sparks disease, hereditary spinocerebellar ataxias, Huntington disease, that is the basic, the prototype of chorea, neuroacanthocytosis, pyruvate carboxylate deficiencies, and other. As I mentioned earlier, there are certain biochemical mechanisms that have been discovered, making a list a long basic the numbers. Inborn errors of metabolism, glutaric acidemia, propionic acidemia, homocystinuria, phenylketonuria, and sulfide oxide deficiency. And as Dr. Nadir beautifully described, paroxysmal disorders as paroxysmal kinesogenic choreoathetosis, paroxysmal non-kinesogenic choreoathetosis, and finally the mitochondrial encephalopathy. So just again to remember, autosomal dominant, autosomal recessive, X-linked, and the mitochondria. These are the four ways of inheritance as a cause of chorea. The drugs, there are so many drugs, they may produce chorea. Anticholinergics, antihistamines, CNS stimulants, amphetamine, methylphenidate, lithium, oral contraceptives, and most widely used anticonvulsants, phenytoin, carbamazepine, and phenobarbital. They are also contribution for the development of chorea. There are certain endocrine causes. Hypothyroidism is the top of the list. Chorea gravidarum, hypoparathyroidism, and pseudohypoparathyroidism, they are the most important ones. A long list of immune or infectious causes that may be responsible for chorea: Behçet disease, primary antiphospholipid antibody syndrome, Sydenham, rheumatic chorea, SLE, systemic lupus erythematosus, bacterial endocarditis, herpes simplex encephalitis, infectious mononucleosis, Lyme disease, microbial pneumonia, viral meningoencephalitis, HIV-related chorea. As far as the vascular causes, they may be associated arteriovenous malformations, basal ganglia infarction or hemorrhage, or they may be vasculopathies or vasculitis associated with chorea, Church-Strauss syndrome, or moya. The metabolic causes, they are very important: hypocalcemia, and hyperglycemia. Both they can give rise to the choreiform movements: hypermagnesemia, hyponatremia and hyponatremia, central pontine marineurosis, and renal failure. They are the metabolic causes. And of course, neoplastic, as there was a huge meningioma in the video that another showed to you, it's primary and metastatic brain tumors may be responsible, or primary CNS lymphoma, they are also frequently associated with choreiform movements. Nutritional deficiency, vitamin B12 and Wernicke encephalopathy, they also are part of as a cause of the chorea. The toxins, the carbon monoxide, the manganese, the organophosphorus poisoning, they can cause. Miscellaneous, they may be part of cerebral palsy, they may be due to head trauma. Again, the same picture, the young chap has a head trauma in the childhood, and then he had on kinesogenic, he has a dystonic posture, or so it may be associated. And it has been also reported in bronchopulmonary dysplasia as well as cardiopulmonary bypass, the post-pump chorea. So these are different causes. They have been added by having a high sensitive, high gadget stacks, so that a number has been added in the recent years. So although chorea is basically a symptom, there may be more than 50 causes of this. But what are the general features of chorea? Because the first thing that has to be decided, it is a chorea. Then we will look for the other causes. Sometimes chorea may not be initially, patient may not be initially aware of, as they are very subtle things. It may be simply attributed to anxiety, maybe restlessness. But And people, they, of course, they having chorea, they also can also suppress temporarily, may giving a rise of something in the psychogenic type of convergent disorder. So it can be stopped temporarily by voluntary efforts or by disengage. But people, they also make camouflage by incorporating them into the semi-purposeful movement. It's a purposeless movement basically. So as he moving and he'll try to make a bal theek kar lega. It's basically a parakinesia. The motor impersistence is important part, but it cannot maintain a sustained posture. As seen when holding a grip, they will alternatively squeeze and release, so it will give rise a milkmaid sign. On tongue protrusion, tongue pops in and out, Harley Quinn's tongue. And then they maybe have drooping of objects and they clumsiness in hands, deep and reflexes often hang up and pendular. Peculiar dance-like gait, as is the name derived from the dance, choreo, the choreography. Other movement disorder can also be observed in the same patient. It may be dysarthria, dysphagia, there may be postural instability, ataxia, dystonia, and myoclonus. So this is basically about the general features of chorea. The cause may be one of the, a long list as I had already showed to you. So I will just give you a very few specific, the clinical feature of diseases. As mentioned, Huntington's disease is the most prototype chorea that has well studied. It's a neurodegenerative disorder and predominantly has cognitive, behavior impairment and movement disorder. Usually begins during adult life. There are certain other varieties, the juvenile Huntington disease, they may present in the early life. It's autosomal dominant disorder and there is a mutation in chromosome 4. As CAG repeats, as the number of repeats are increased, it will tell you the age of the onset. CAG normal function is codes for glutamine. When this gene will be overworked, it will produce more glutamine. Although I know it seems to be this slide, but I make it on the one slide because it will give a good impression to be remembered. So as the physical findings, that there are different stages of the Huntington disease. As the initial finding, the first sign, if somebody picked up, it's a slowed saccadic movement. Basically, there is another loop that is still understudied. It's the oculomotor loop that works with the striatum. So it's the first sign of Huntington disease is a slowed saccadic movement. Chorea predominates movement disorder in 85%. And then in the juvenile form, its most important prevalent is the Westphal variant. If it's the Westphal variant, is basically it's a rigidity and bradykinesia and tremors, dystonic posterior ataxia associated with mental retardation, seizures and myoclonus. They are usually seen in the juvenile stage. As the adult case, the chorea remain a prominent feature of the Huntington disease with bradykinesia and posterior reflex compromise, frequent falls. And the terminal cases, dysarthria, dysphagia, and finally respiratory difficulties. It is also, of course, dementia, cognitive impairment has to be there, depression and psychosis. So basically, it's a neuropsychiatric disorder or with memory impairment, with positive family history, parents has to be with the disease. This is all about the Huntington disease. A very brief about the Wilson disease. Again, this is whenever a patient came to either with chorea or any movement disorder, the first thing that has to be done is the slit lamp eye examination for KF rings. The Wilson disease is very important too. It's autosomal recessive disorder. The hepatic dysfunction is usually starts at the 11 years of age and neurological dysfunction start after 19 years of age. So in bachon mein hepatic presentation is more and adults it's the neurological dysfunction is more. It's the abnormal copper metabolism and this copper is deposited in the tissues not on the normal side, it's the pathological side. Normally copper is present in the nerves, in bones, in melanin, so it's already present there, but it's the excess, it may be eyes, it is in the brain basal ganglia. The findings, as I told, children the hepatic dysfunction predominates, sardonic smile and behavioral issues seen as the earliest presentation. In adults, neurological dysfunction predominates and Parkinson features, maybe marked dystonic postures. And of course, the psychosis, psychiatric symptoms are there and patient usually have the KF ring on the slit lamp eye examinations. Choriocanthocitosis, As the case has also been presented, acanthocytes, detection of acanthocytes, a simple peripheral blood smear, it can diagnose a neuroacanthocytosis, but actually it's the absence of chorin on the erythrocyte confirms the diagnosis. Again, a long list of the clinical features. It may present with tics, it may present behavioral changes, subtle cognitive dysfunctions, chorea, Parkinsonism, lingual buccal facial dystonia, seizures. About 40% of cases can be seen with acanthocytosis. Motor neuropathy with reflexia and muscle atrophy is typical for neuroacanthocytosis. Dystonic tongue protrusion on eating strongly suggests this diagnosis. So these are the few points that if you remember these few points, you can diagnose, and it does not require the chorin test on the erythrocytes. You can just simple peripheral blood pressure identification of acanthocytes is diagnostic for chorioacanthocytosis. Dubek syndrome, UDC in the Filipinos, the features are dystonia, Parkinsonism, chorea, tics and tremors and myoclonus. Leak syndrome is a various mutation in mitochondrial DNA, is one of the mitochondrial inheritance. Usual onset is early childhood. Neurological finding a long list. It acute encephalopathy, psychomotor retardation, hypotonia, spasticity, myopathy, seizure, dystonia. So basically there are a lot of things that can be added. The only thing is just to remember that chorea has a lot of causes, inherited causes. Of course, it must have family history. Leishman syndrome, mutation of hypoxanthine phosphorybosyl transferase resulting in the accumulation of the uric acid. It presents at 3 to 6 months with these psychomotor retardation, hypotonia, spasticity, dystonia, chorioathetosis and self-mutilation with biting of the hands and lips is the classical features. And uric acid is classically, of course, it's an X-linked disease. Boys will be affected, though it has you have the gout. This, as for the few slides for the treatment, believe you me, the treating any movement disorder is really a disabling. Either once you diagnose the case, symptomatic treatment has to be given, and it mainly stay is in the medical. And then as for the neurodiabetes, they are the mainstay. The typical is haloperidol and flufenazine, and atypical is for the risperidone, olanzapine, and clozapine and quetiapine. They are very useful for the chorea movements. There are dopamine depleting agents. As I told you, they are decrease the dopamine in the striatum that will improve the chorea, razapine and tetrabenazine. GABAergic drugs, as we know, the neuronal that contains GABA, they are lost in the striatum. Clonazepam, gabapentin, valproate, they are also useful for treating the chorea. Coenzyme Q10, there are also people they have worked on it, and it seems effective in treating the chorea. IVIG and plasmapheresis has also been reported very useful in especially in the rheumatic chorea, Sydenham chorea, and after cardiac transplantation, steroids is also helpful in relieving the chorea. I go through in the literature very deeply. Still there is no good evidence of these two, but people they are using in different as a very case report. In some cases one report, in some cases two cases. The deep brain stimulation has been used for treating the chorea, but still there are no promising results. Neurocell transplantation again has been used by many centers recently in 2004, 2008, but again there is no meta-analysis, good studies to say you can infer something. And thank you very much for the patient listening.
We can entertain a couple of questions for Dr. Numan. Introduce yourself, please.
My name is Dr. Sajjad Ali. I am working as assistant professor of neurology at Sialkot. One of my teacher, Dr. Ahsan.
Introduce yourself, please.
My name is Dr. Sajjad Ali. I am working as assistant professor of neurology at Sialkot. One of my teacher, Dr. Ahsan. One little question in the treatment: can we use benzodiazepines? In your scheme, I could not see it. Whether I was confused. We frequently are using it.
Clonazepam has been written there. It's a gabapentin, clonazepam, valproate is written there.
This is
Yes,
gabapentin.
it's a benzodiazepine.
Thank you very much.
I should mention the category is clonazepam. I mentioned it. Once again, thank you very much, sir.
Thank you very much, Dr. Numan.